We are live in YouTube. We are starting the webinar in 5, 4, 3, 2. We are live with the webinar.
Ignacio, is it okay?
Yes, okay.
Okay, good evening. Ignacio, we can stop the music. Thank you. Ignacio, okay, thank you. Welcome everybody to the monthly University of Miami Symposium of Skull Base or Cerebrovascular. It is session number 39 for us on today, October 28. We have a spectacular panel for you, which I will introduce them at the end in a few minutes. We are here, you can see in that shaded box where we are along the path of lectures we've been doing, 2 more before the end of the year, and we're in the process of preparing the program for 2022. David Altschuler, my current Cerebrovascular Skull Base Fellow, will be joining us to show a case as well. And Eva Wu, first appearance on our Zoom. Welcome, Eva. She's a PGY3 with us, and she will also show the panelists a case at the end. I'm Jacques Morcos, professor and co-chair of the department here, and the co-directors of the course are Carolina Benjamin, Mike Ivan, Bobby Stark. By now, I'm sure you know all of them, and because I know most of you are repeat offenders in the audience, so I'm not going to waste your time and introduce everybody, reminding you we also, our department puts together a wonderful pediatric symposium on some Mondays, organized by Toba Niazi and Heather McRae, along with John Ragib and Shelley Wang. Don't miss that. This is, for example, what the last one, the Mike Ivan, my partner, who puts together a fantastic Miami Global Brain Tumor Symposium, first Wednesday of the month. For example, that was the last one on October 6th with Jeff Bruce, and the next one will be the first Wednesday of November. Don't miss that as well. For this symposium, next one is November 18 on acoustic neuromas and petroclival meningiomas, as hard as it gets, with wonderful speakers, Jim Liu, Greg Thompson, Mike Link, and Nick Bambakidis, to discuss those 2 formidable lesions. And I'm sure if you're interested in skull base, you don't want to miss that. Many thanks to the team here at the University of Miami that makes all this happen, particularly Ignacio Escalona, who's been with us doing these webinars the last 2 years now, since really April of 2020, almost. If you are interested in reviewing all of the recordings of all the past sessions and future sessions, you can connect on that link in that yellow box or contact me by email, or Ingrid Menendez, our education coordinator, on her email, and Twitter accounts for the department, and Instagram, and so forth. The format, as you know, we've been inviting 4 internationally known speakers. We've asked each of them to speak 20 minutes. And then when there is time, my fellow or resident will show a case or two for their opinion. And of course, we're going to tackle the questions from you, the audience. Put your questions throughout the session in the Q&A box, not in the chat box, Q&A box, and I promise we will get to them. So speakers tonight, in the order in which they will speak, wonderful pleasure to have Elad Levy, Professor and Chair of Neurosurgery, University of Buffalo in Buffalo, New York. Elad, and congrats to him also for being now the president-elect of CNS. So his meeting will be not next year, the one after. You don't want to miss that. Elad, of course, has been a formidable force, particularly in endovascular neurosurgery, and he's going to talk to us about a provocative title today, The Progressive Extinction of Craniotomy for Aneurysm. Welcome, Elad. So next speaker is my good friend from Pablo Rubino, who now has moved to a new position in Buenos Aires, Argentina. He's the chief of service at the German hospital. Pablo is one of, has done Evandro de Oliveira Roten Fellowship. He's an accomplished neuroanatomist and a master cerebrovascular and skull-based surgeon, and he's going to try to perhaps give the counter of that and tell us why there is an essential need of microsurgery in the treatment of aneurysms. Third is Felipe Albuquerque, Professor and Chief of Interventional Neurosurgery at the BNI, and Felipe certainly needs no introduction either. And he is the president of the wonderful society called the SUN, Society of Universal Neurosurgeons, and that's what he and I look always forward to, those trips. And the next one that he's the president of is in Prague later in 2022. And of course, Felipe has been phenomenal innovator in endovascular as well. And he's going to tell us how to crack the safe through the endovascular approaches to the cavernous sinus. That's also a fascinating topic. And last but not least will be Greg Zipfel, who is chair of neurosurgery at WashU. Greg has been involved in multiple positions in AANS, Senior Society, CNS, and he's going to talk about optimizing outcome during aneurysm surgery, the importance of intraoperative vascular assessment. So you see, we have a full slate tonight, and I'm going to stop talking and I'm going to invite Elad to share his screen, unmute his microphone, and talk to us about his provocative topic. Elad, it's all yours.
Thank you, Jacques, for the kind invitation and to share with this esteemed panel. It's truly a privilege to be here. And again, thank you for your commitment to education in neurosurgery and doing these symposiums throughout last year and this year. It's truly a yeoman's effort. So to be sensitive to the time in the next 20 minutes, I'm hoping to create the case that demonstrates the obvious progressive extinction of craniotomy for aneurysms. And if I look back to when I was a resident, maybe 5–10% of aneurysms were being done via an endovascular approach. But now truly the pendulum is switched, and maybe 85% of aneurysms globally, or at least in more developed countries, are being done through an endovascular approach. Disclosures are here, none really relevant for this talk. And to know you have to know the past to understand the present. And where we came from is very important, because everything we do builds on these predicate devices or predicate knowledge. And you can see in just a very short time, in decades, the field has evolved tremendously. And really in now years, endovascular develops at a breakneck pace. So the question we should be asking really now, once we understand where we were and where we are, is where will we be? Where can we be? And we've come a long way. And I like to show this video from our archive here with Nick Hopkins, my mentor, former chair here at Buffalo. So this is circa 1999, 2000. He does 2 aneurysms this day, 1 clip, 1 coil, in the very early starts of coiling.
Okay, good. A little headache, a little sore up in here. And that's just from the incision. That'll go away soon. Hello, Mr. Miller. Hello. How are you doing this morning? Good. Good, good, good. Good to see you. Still want to go home tonight? Yep. Okay.
This is 1999, showing 2 aneurysms done the same day, really foreshadowing what's to come. He's going to go home the same day. Obviously, we keep these patients overnight, but for video purposes, he's going to go home the same day. And the other patient, big bandage on her head, craniotomy, lying in the ICU. So this is where we were. And as you know, Dr. Drake, just across the border, London, Ontario, the epicenter for basilar artery aneurysms, everyone was shipped over. And I had the pleasure early in my career to understand a little bit about what he was doing and the barriers he was breaking. Here is an op note on a patient that the patient actually gave the patient for a ruptured basilar aneurysm from Philadelphia, sent to London, Ontario. And this was his first awake Hunterian ligation. He woke the patient up, ligated the vessel, the basilar, see if he tolerated it, put the patient back to sleep. And he says, this is the first time temporary occlusion of an intracranial artery has been carried out in a patient who is awake to test the collateral circulation. I think it may be the forerunner of many more to come. And this patient makes history. And then 30 years later, he happens to present with a recurrence above the ligation. So you can see as this flame-shaped basilar tip aneurysm reconstituted through the Pecan, and he makes history again, because understanding where we were and what he went through, this is the first case now. He was the first case of an awake ligation. Now he's the first case of a trans-Pecan stent-assisted coil, and we published this paper. So I like to show sort of this very rapid evolution and this timeline where you see in 1990, the coils are invented. By 1999, we sort of have 3D modifications and then stenting for aneurysms a few years later. 5 years later, we have another stent. 5 years later, we have flow diversion, new improved flow diversion. And then this year and last year, now we have surface modifications, which may open the whole world of subarachnoid hemorrhage to flow diversion. So let's kind of go through how these devices evolve and how we can do better. Just like the operating microscope changed how we operate on aneurysms, and again, opened up a whole new world of microsurgery. This is what flow diversion looks like under standard angiography. But in the past few years, our center, as well as others, have developed high definition angiography. And just like the microscope allows you to see much better, look at the difference under high def. And I don't know if it projects well, but you can see the stent times. You can see the stent now is not opened. You can see that it's twisted, it's torqued. We can now fluff the stent and spread the stent and compact the stent and really be much more careful and much more meticulous about where we deploy it. You can see it's not open here. Before, you wouldn't be able to see this, but under high def angiography, you can see perforators and better positioned coils and devices. This is 1,000 frames per second. This is new technology, not yet for human use. It's being developed in our lab right here. A lower radiation, but 1,000 frames per second. And I'm going to show you what conventional looks like. So this is conventional. Oh, let's see if that video plays. Will it play? This one won't play, but you know what an angiogram looks like. Imagine what you can understand about blood flow, aneurysms, flow diversion. This is a web device, which I'll show you later. And you're seeing this under 1,000 frames per second. Typically, we run at 16 frames per second or 5 frames per second, 20 frames per second. This is brand new technology that we believe in the next year or two is going to change the way we look at the cerebral vasculature completely. So coil embolization, we all know. I'm not going to spend too much time on it. But in general, again, it's changed the landscape for simple, narrow-necked aneurysms, for sure in the elderly population, and also patient drivers. Patients are educated. They can see things on Twitter. They see things on Instagram. They see things on Facebook. They go on PubMed and read papers. They can make decisions about, do I want craniotomy or do I want awake coil embolization for a half hour and go home the next day, or maybe even that next day. So we can now, with complex coils, we can treat complex aneurysms. So here's a patient who comes in with a new third nerve palsy. She has an irregular Pecan aneurysm. As you can see here, it looks like a snowman because we live in Buffalo and everything we think looks like a snowman. So of course we can decompress a third nerve and clip this, but we also know that we can coil this, and many of the patients do get better. So here's that snowman configuration. And as coils have evolved in three-dimensional shapes and smaller distal loops and gel coatings and all these other things that we have available to us, we can just use these complex coils and create complex techniques. And in this technique, we call it the Snowman Technique. We coil the head of the snowman first, as shown here. We link the bigger coil into the head, drag the catheter back, and continue now to coil the body. So we can compartmentalize the aneurysm, standard coil technique, and we'll put another coil in the interest of time. You don't have to watch. You can see there's some residual there. We'll put a last coil in. There you see residual. We'll put one last coil in to coil the base. So even though it's relatively broad based, and even though it's irregular, these used to be no-nos for coil. These used to be, you have to clip these, but you can see you don't. Complex coil configurations have allowed us now to treat complex aneurysms. So pros of coiling: can be used as a standalone or in combination with any endovascular device. It's ideal for aneurysms with narrow necks of patients of any age. You don't need dual antiplatelets. You can coil the aneurysm, sacrifice the vessel. As I said, you don't need antiplatelets. Some of the cons: can be difficult if it's a wide-necked aneurysm, so you may need adjunctive device. And it does require more finesse than just papering the parent vessel with a stent, and you have a risk of coil herniation, so there is some finesse. So let's escalate the complexity to balloon-assisted coiling. Many balloons now. The technologies of balloons have evolved tremendously for bifurcation balloons, sidewall balloons, balloons with lumens that you can put coils through or wires through. So here's a large ruptured anterior communicating artery aneurysm, kind of standard technique for balloon-assisted coiling. Here's the rupture. We'll talk about the fact that you don't want metal in the parent vessel in a rupture because you need dual antiplatelet therapy, and that becomes challenging with EVDs, ICU lines, other things that a patient may need in the critical setting of a ruptured aneurysm. But again, here you can see the aneurysm. It's a large A1, A2 junctional or ACOM aneurysm. Here you can see the balloon is across. It's in position. Once you have the balloon inflating, once you have the optimal views, we can inflate the balloon either under monitoring or awake, depending on what the status of the patient is. 2 catheters, and here's your coiling technique to prevent herniation of the coil into the parent vessel. You can see under the balloon occlusion, we get a very nice result. Small residual at the neck, but here you can see the final result, almost coiled to the neck, parent vessels preserved. So the advantages of balloon-assisted coiling: you can get a tight pack all the way to the neck. You don't need dual antiplatelets. It does increase the risk of thrombosis or vessel injury, so you have to be careful. And the newer technologies is very rare, but of course it's a risk. Stent-assisted coiling. As we continue to create more technology, there are more aneurysms that we can treat. Again, creating the extinction of craniotomy for most aneurysms. So here you can see different configurations. You have what's called a cross court across the ACOM. You can have Y stenting, as is shown here. I love this configuration. We champion this a lot, the elbow or the L stent. So it avoids two stents, less metal. You basically force or push the stent out as opposed to unsheath to create an acute bend here, a 90-degree bend called an elbow. So here's a giant cervical ICA aneurysm. So this is a rapidly enlarging aneurysm. She had neck surgery for another issue. They found afterwards that she was developing an aneurysm. She was sent to our service. So here's the technique. We have a balloon guide there in case of rupture. We access the giant aneurysm with a coiling catheter. We want to put a few coils in. Okay, there's the aneurysm, the ICA, the ECA. Now we bring up, in this case, a self-expanding stent, as is shown here. There's a kink here to the discerning eye, but that's okay. There is a coil here preventing prolapse of the stent into the aneurysm. You can already see there's some flow stasis. So now we're going to coil the rest of the aneurysm before addressing the kink in the stent, because I don't want to push the stent into the aneurysm. Right there, we're going to pop the kink with sort of a beefy wire, a beefy curved wire. And this whole thing can be done awake. It's a giant aneurysm. We can do awake in about 30 minutes. And it makes complex pathology very straightforward. The pros: tighter packing of an aneurysm with coils. It allows for coil embolization where the anatomy makes primary coiling unfeasible, like in that giant aneurysm. Ideal for wide necks, especially if there's a concern if the balloon, when the balloon is deflated, coils will come back in. And there's no flow arrest like when you have a balloon. Of course, there's an increased risk of thrombosis, which is why you require dual antiplatelet therapy. Other devices now, Comenici device. Imagine everything we had a problem with the balloon arrests flow, the stent is permanent. Can we sort of put a temporary stent in there so you don't arrest flow, take the stent out so you don't need dual antiplatelets? It's a wonderful technique, especially in the setting of a ruptured aneurysm. So here's another anterior communicating artery aneurysm as shown here. So again, we bring up our first microcatheter across the aneurysm to position the Comenici device, as is shown here. Here's the Comenici device, all the way across the neck of the aneurysm. Here's a second microcatheter in the aneurysm. And now we just deploy coils with the Comenici here. You can see unsheathing the Comenici device as is shown right here and right here. So before we unsheath too much coil, so now we've bridged the neck with a temporary bridging device, this Comenici device. You can see the stent is pushing on the coil to create protection of the parent vessel across this wide neck. We now recapture, we sort of deflate this device or make it skinny, recapture, and there we go. So advantages: tighter packing, coil embolization, no dual antiplatelet, no flow arrest. It's a temporary device. There always is a risk for thrombosis whenever you put anything in. So in the last 5 minutes, to be sensitive to the time, I'm going to start focusing on flow diversion. That's really been a game changer now. So if you don't want to put coils, if you don't want to access the aneurysm, if it's a difficult neck, difficult angulation, this is a much more straightforward technology. And I almost feel it's creating a dying art. Coiling is becoming a dying art, and I hope it never does, because it's a fantastic treatment. So many flow diverters, we're not going to get into the nuances of which is better or what are the advantages and disadvantages of which, but we'll just show you sort of a standard flow diverting technique here. So this is perfect for flow diversion. Look at this dysplastic, irregular, multilobulated carotid aneurysm near the ophthalmic segment. So in this case, we used a different guide, but we're not here to talk about the guide. We're here to talk about the aneurysm. So once we can navigate across this dysplastic aneurysm and get distal purchase, as is seen here, the whole case becomes very simple. The anatomy of the aneurysm almost becomes irrelevant at this point. It just, once you navigate it across, we're going to just create a new pipe, a new corridor, as is going to be shown here. So here we are unsheathing the flow diverter. So again, the anatomy, once it's crossed, has become irrelevant. We've taken a very complex process, which I think personally, surgically, would probably need to be trapped or would need to be occluded and bypassed, sacked and bypassed. This is an awake procedure that can take 30 minutes, 40 minutes, or you can do it asleep if that's more comfortable. So pros, can be used as a standalone, or if people like to put coils in, so be it. Ideal for complex anatomy, as is shown here. Perfect for wide neck, fusiform dissecting aneurysms, especially in the larger vessels like ICA, basilar, or vertebral. There is a learning curve. These don't always go perfect, so I don't want to minimize that. You need dual antiplatelets, so for subarachnoid hemorrhages or patients who have bleeding diatheses, GI bleeding, nose bleeding, rectal bleeding, or need other surgeries, this would not be appropriate. So also understand the patient's comorbidities. You don't have an immediate obliteration. It takes 6 months or so for these to heal in, sometimes a year. And here we published a paper called Nuisance Bleeding. So about 20, 30%, 20%, 25% of the patients have nuisance bleeding. They don't need a transfusion, but they come to the hospital for nosebleeds, rectal bleeds, joint bleeds, because they're on dual bruising, because they're on dual antiplatelets. So we don't want to mitigate the role of dual antiplatelets, though I think it's a wonderful technology. The other side of the coin is about 27% in 250 cases had nuisance bleeds. The new era, surface modification. In this, there are other companies that have it, but there are, Pipeline Shield is one of the closest ones to being readily available across the globe. There are others in Europe, but you can see in vitro studies, much better anti-thrombogenicity. So unlike standard flow diverters, these are more protective against creating thrombus, as is seen in multiple studies and multiple animal studies. So can you use these in subarachnoid hemorrhage? Can you use these with single antiplatelet therapy? We don't know the answer to that, and I would caution right now, no, until we have human data to suggest that. But the trial that we're embarking on with several other centers, and if any center is interested, please let me know. We're about to start that trial. Is instead of 6 months of dual antiplatelet therapy, can we do 8 weeks on the first arm? And if they do well, 6 weeks. And if they do well, 4 weeks. Can we do single agent? And that's the trial we're going to be looking at. So I know I only have 1 minute and 44 seconds, or 1 minute 44 left. I'll show sort of one last case combination. It's a pipeline Elvis or a pelvis, if you put them together. And that's kind of putting everything together where surgery fails. So let's look at that really quickly. So this is a patient who had a ruptured aneurysm, ruptured Pecan aneurysm. He was clipped at another institution and then re-ruptured. Years later, it was lost to follow-up and came back and was coiled. And this is sort of how we see him. So when we first see him, he has clips, he's got coils, he's got a massive recurrence, he's already ruptured twice. What are we going to do here? We can't recoil this. We also can't simply flow divert it because he has a large PCOM coming out of the aneurysm. So this is going to require all the modalities we just talked about rolled into one. So the first thing we're going to do is find this PCOM here and protect it, because if we just put a flow diverter, this will act as a sump. It's going to continue to pull blood, and we're not going to be able to occlude this aneurysm. So the first thing is, let's protect that PCOM from when we put coils in, we don't want to lose it. Sort of was borderline fetal. So the first thing we do is wire that. Now we bring our catheter into the PCOM, as is shown here, and we place a small self-expanding stent just to the edge of the carotid, as is shown here. Once we do that, we bring up our flow diverter catheter, and we have another catheter inside the aneurysm. So we have our flow diverter across, catheter in the aneurysm. Now we're going to coil the rest of the aneurysm closed and then seal the aneurysm pretty much with a flow diverter in the parent vessel. So this is what we have after coiling. Coils are protected from coming into the PCOM. We place a flow diverter, and this has been now stable for many years. showing stent, coiling, and flow diverter for a recurrence after clipping. And with that, I'm out of time. And Jacques, I want to thank you and be sensitive to the rest of my panelists. And I'll stop sharing.
Thank you, Elad. This is a wonderful, quick view of state-of-the-art endovascular management. Of course, you can talk hours with some of these complex cases. We're saving questions till the end. Greg Zipfel, unfortunately, has to go to the OR, so I'm changing the order of speakers. So Greg, welcome. Why don't we have you speak next in case you have to leave us for the acoustic?
Okay, thanks for the invitation. Sorry to the panelists to disrupt the flow here, but I probably will have to go back to the OR here in a little while. But I appreciate the invitation. I'm going to have kind of a really pragmatic discussion about how to avoid complications while doing aneurysm surgery that Elad says will be gone in 2 years, I think. But that's okay. Until then, we'll need to make sure we're doing the best we can during our open aneurysm surgery. And I'm going to make the case that I think a complementary use of intraoperative aneurysm assessment tools is important to optimize outcome. No disclosures of interest. The goal here is aneurysm clip application that allows for a complete obliteration of the aneurysm, flow through parent and branch vessels, and flow through perforators. That sounds, relatively simple, but we know from past studies, that without the use of intraoperative assessment tools, that this can be fraught with issues after aneurysm clip application, where vessels can be occluded and aneurysms can continue to fill. And so that led to a number of development and application of tools to help lower those numbers so we can really do the best for our patients when they need surgery. The tools that are available to us largely are Doppler, a flow probe, endoscopy, video angiography, which initially was Icg and now also includes fluorescein and intraoperative catheter angiography. And the Doppler, I think, has been around for a long time and is simple to use. The device is easy to apply to vessels. You can use it somewhat to look for aneurysm flow in the dome, but I think primarily we're using it for making sure there's flow in branch and parent vessels. The key here is its velocity. It's not actual flow, but it is easy to use and can be useful in a lot of situations. I like to use the flow probe much more regularly, and the reason is that it really provides immediate quantitative flow. So you can tell if a branch vessel is stenosed, which is sometimes more difficult with a qualitative assessment like Doppler. You also know antegrade versus retrograde because of the arrow that's on the device. So you know what direction of flow that you're getting, which can also be confusing at times with proximal occlusion can lead to retrograde flow, which is interpreted as good flow when in fact it's retrograde flow. So this is another tool that was devised by Fadi Charbel up at UIC, and the key there with that though is that the smallest vessel that you can, the smallest aperture that it has on the device is 1.5 millimeters, and so smaller vessels sometimes are a little bit more difficult to accurately assess with this tool, and it's a little bit more cumbersome to get in and around the vessel. So there's occasionally areas where it's more difficult to use. Endoscopy is something that's been reported. I personally haven't used it much, but what you can do is after the clip application, you can look across the neck and the area that might be difficult with the microscope to view to see if your clips are completely across the aneurysm neck and or if there's any perforators in the clip blades. So the endoscopy allows you to look around corners and can be useful at times. The Icg Video Angiography has been really a very welcome addition to our ability to assess adequacy of clipping for parent branch vessels and the aneurysm dome. This is an Icg. The nice thing, it's a very nice tool. You can tell, though, you can't see the surrounding structures because it's infrared, while later fluorescein been applied. And here you can see the anatomy and the fluorescence. And so they each have their own kind of pros and cons. The fluorescein video angiogram, in my experience, is much better for deeper lesions. The intensity of the fluorescence is better suited for that, while the Icg has some difficulty with that. The downside of fluorescein is that it doesn't wash out very quickly. and it's hard to use repetitively, while ICG washes out more quickly, and you can do 2 or 3 runs of ICG spaced out over minutes or something along those lines. So they both have their kind of pros and cons. And then the gold standard is intraoperative catheter angiography, like you see here. It's obviously exquisite anatomic detail. The issue there is that there's some delayed assessment depending on if you're calling in your angio team or if you're the person who's going to be doing the intraoperative angiogram, but there's some delay in getting this done and then making clip changes when necessary. It also doesn't show perforators, and it's not quantitative as it relates to flow either. So if you take all those tools and you kind of look at all the things we're trying to get, aneurysm occlusion, vessel patency, perforator patency, immediate assessment, and quantitative, none of these tools really hit all the buckets. And so that's an issue that, we'll talk about it later in my talk. But there's no tool that is perfect at this point. Let me just look at catheter angiography. This came on in the 90s and maybe a little bit earlier than that, in terms of studies like this that came out of WashU, and other centers had similar studies where they looked at what's the utility of intraoperative angiography for aneurysm clipping. And what you'll see here is that, at least in our series, 98 out of 234 clipped aneurysms, there was a 7% unexpected residual aneurysm noted on the intraop angiography, and leading to alteration in the clip. And so this clip repositioning rate that is somewhere in the 7 to 17% range, depending on your series that you're looking at, is significant enough that I think a lot of us at the time felt that intraoperative catheter angiography was really useful. Now, if you look at this as 1997, there was no video angiography. There was Doppler, there was not flow probe. And so, you could argue that these other tools that could be applied weren't at this time, and maybe over time with this application of these other tools, maybe intraoperative angiography is no longer necessary. Again, this range of 7 to 17% has been reported in the era when we weren't using complementary tools like fluorescein or ICG video angiography or the flow probe. And so that led a lot of people to believe that intraoperative catheter angiography was important for optimizing care. Now, then that became, if you're going to use it, are you going to use it routinely, or are you going to use it selectively? And there were studies like this is out of Barrow, where suggested that perhaps if you perhaps you could, in a selective way, use intraoperative angiography, basically based on the surgeon's impression on the complexity of the case and whether an angiogram would be necessary or not. So what they did here was a prospective study, 200 straight patients, 234 aneurysms clipped, and the attending surgeon was asked prior to the surgery, would an angiogram be necessary based on the preoperative imaging? Was it complex enough that it would require it? And you see the responses, 80% no, 20% yes. Then they went to surgery, all patients got the angiogram, and they looked at what happened. And what they saw is when the angiogram was necessary, that almost 20% of the time, there were clip adjustments required based on the intraop angiogram. So they were able to pick the higher risk group. But in the other group, the angiogram not necessary, there still was a 4% risk, or 4% incidence of vessel occlusion or aneurysm incomplete obliteration that led them to believe that intraop angiogram really should be done on a routine basis, because we can't selectively pick out those that won't be required and would be useful. That led us to, I read that and I really was intrigued by that, and we wound up doing our own study. And my thought was, if we prospectively did the same thing, except instead of asking prior to surgery, you do it in the surgery. The aneurysm's been clipped, you've seen the aneurysm complexity, if there are branch vessels that you're worried about, about atherosclerosis and things of that nature. So I thought that if you asked the surgeons after they clipped it, but in the operating room, you would be better at determining whether an intraoperative angiogram would be required or not. But what we found here is that we still, despite patients or surgeons feeling like it was adequately clipped after the surgery, that we still had 5 cases that required adjustment of the clip, 2 for vessel occlusions and 3 for aneurysm remnants. And that we concluded that really the surgeon impression, even after you clip the aneurysm, should be viewed with caution, and routine use of intraoperative angiography was still required. Now, again, if you look at that, that was 2012, and it was just beginning with the ICG Icg video angiography being applied to aneurysm surgery. We have looked at this. We all appreciate the value that the Icg and fluorescein video angiography has. This is an example of where it really tells you the whole story. The aneurysm's been clipped, and all the parent branch vessels are patent, and perhaps we don't need an intraoperative angiogram for this kind of case. And there were papers coming out looking at the utility of the Icg video angiography, and you see the years that this was happening, but certainly the later years there were a suggestion that the Icg was 93 to 100% as good as intraoperative angiography based on post-operative vascular imaging. Yet we were seeing things like this. This is a 42-year-old with a large, almost 2-centimeter ICA aneurysm. Went to surgery on the right ICA, the right MCA, the right A1, and the aneurysm is back in here at the distal aspect of the aneurysm. And here you see to the right, the aneurysm clip applied. We see parent branch vessels patent, and when we look deep in the optical carotid region, we saw the ICA filling well with Icg. And this was interpreted as complete aneurysm occlusion and patency of the parent branch vessels. However, the intraoperative angiogram that was done suggested otherwise, that although the aneurysm was clipped, the carotid distal to the clips were also occluded. This was a discordance. This was an error in the Icg, or at least the interpretation of the Icg and the intraoperative catheter angiogram. And we wondered whether these reports that had looked at postoperative imaging, were they as accurate as it appeared. Here's another case of an anterior communicating artery ruptured aneurysm that was taken to surgery. You see the right A1 here, left A2, left A1. The right A2 is actually covered here, and you can't quite see it on this one image. On the pre-clip Icg, you see the right A2 here, and then so we saw the branches pre-clipping. We then clipped that aneurysm, and you can see the shadow of where the clip was. We saw the right A1. It was a fenestrated clip around the left A2, which looked very patent on this Icg. And later, when we manipulate the vessel superiorly, we can see the right A2 is patent as well. That'll show up here in a second. But what's important, I'll call your attention to, is the left A2 really looked patent, but was fenestrated by this clip. But when we did the intraoperative angiogram, the first one, the left pericallosal, left A2 was not visualized. We went back and made a clip adjustment, and this follow-up angiogram showed the left A2 present. So this is another example of discordance between the Icg and the ultimate intraoperative angiogram that was performed. So we went back and looked at about 50 patients. This is a retrospective analysis, about 50 patients who got both the Icg and about 4% got an adjustment based on the Icg. And then they got, if it looked good on Icg, they got the intraoperative angiogram, but 8 times, 4 for remnants, 4 for vessel occlusions at a rate of 16%. There was a discordance that led us to change the clip application after the Icg suggested it was okay, but the intraoperative angiogram suggested it was not okay. And a hint that perhaps this is particularly common in the region of the ACOM. And so our observations with this is that out of field view can be missed because the Icg requires a direct line of sight. If you have retrograde flow or collateral flow, that can mask vessel occlusions. And complex anatomy or deeper locations like ACOM also seem to be areas where this discordance was particularly common. We published that, and what was interesting is, although people talked a lot about Icg and its utility, once we published that, the number of very well-known vascular neurosurgeons that pulled me aside at meetings and said that they had a similar experience was quite high. And so I think that some caution relying totally on the Icg or fluorescein video angiogram should be had. So if you go back to those tools, there's 5 areas we're trying to hit. None of the buckets are obtained by any one tool. So I think that you really need to use a combination of complementary tools to really optimize your aneurysm surgery, make sure the aneurysm is completely obliterated, parent branch vessels are patent, and perforators. And my personal preference is to use the flow probe for branch vessels. I like to do pre and post clipping for vessels that I feel like are going to be at potential harm related to fenestration of a clip or atheroma or things of that nature. I do Icg or fluorescein video angiogram for immediate feedback. They're particularly nice for perforators and to make sure the aneurysm is completely obliterated. But we still do at WashU a routine intraoperative catheter angiogram to be 100% sure that we have had the most safe and effective surgery possible, and then we close. And with that, I'm happy to take any questions, or I guess we're taking questions later. But thanks again to the panel for flexibility. Thanks, Jock, for the invitation, and it's a real treat to be with all of you tonight. So thank you.
Thanks, Greg. But considering you might leave us later, I'm not sure if the panelists have any. I don't see. Let me see if there are any. Anybody has question for Greg, just in case he leaves us. No, I don't see any question to you from the audience at this point, Greg.
Okay.
But no, when your paper came out, for sure, you're right. People kept talking about it, the false negative, false positive of ICG and so forth. Felipe or Pablo or Ilad, any questions or comments about Greg? Otherwise, we'll ask Felipe to. Thanks, Greg. Felipe, go ahead. You're muted, Felipe.
Can you see my slides now?
No, you stopped sharing, I think.
All right.
It showed briefly, and then yes, we see your desktop. Yeah. And go to the top left, like Ignacio said, because we see two slides.
Okay.
Perfect.
Right.
Thank you.
Thank you, Jacques, and the rest of the panel. I'll talk today about something that I'm sure will not go into extinction, and that's the endovascular treatment of carotid cavernous sinus fistulas. I have no disclosures today that are pertinent to my discussion. This is an interesting area. I've spent a lot of time in this particular region of the cranium, and have learned over my experience that there are numerous routes into the cavernous sinus, all of which we need to master as endovascular neurosurgeons. But even more important than the routes in are the routes out. I would point you to this manuscript recently published by Phil Myers and the UCSF group that beautifully describes some of the clinical symptoms that precede actual presentation in patients with indirect carotid cavernous fistulas. And I'll talk a little bit about direct fistulas as well. So I mentioned that there are a number of routes into the safe. There, as you can see here, the direct puncture routes through the superior ophthalmic vein and the inferior ophthalmic vein. The trans inferior petrosal sinus route, which you can use both ipsilaterally and to tackle contralateral lesions. The trans external jugular vein route, which is a much more complex route in which we traverse the facial or angular veins typically to enter the orbit. And the transinternal carotid artery route, which is a newer iteration of a technique that we developed with flow diversion, and I'll discuss that very briefly. The routes out are critically important, and these often need to be blocked in order to lead to amelioration of symptoms. So certainly in those patients that present with ocular symptoms, you need to make sure that the superior and inferior ophthalmic veins are closed. Often you'll have to close the inferior petrosal sinus as well. The superior petrosal sinus, another route out of the cavernous sinus, as is the middle cerebral veins, which are critically important, and I'll show you an example of why. The middle cerebral venous trunk generally arises from the anterolateral inferior aspect of the cavernous sinus, and the basilar plexus, which drains posteriorly from the cavernous sinus and often drains into the cerebellar veins. So as illustrative cases, this is a 59-year-old woman who presents with a new onset of proptosis. The proptosis is on the left side. Interestingly, we see here multiple feeders from the internal carotid artery on the contralateral side as well. Here's her superior ophthalmic vein on the left side. And carefully, if you look at this very carefully, you can see here faintly cerebellar veins that are draining from the posterior aspect of the cavernous sinus. And this is critically important and something that I did not appreciate at the time of treatment. So we assessed her external jugular system. This is a route that I enjoy taking. You don't have to puncture the superior ophthalmic vein. You can traverse the external carotid artery. In this case, this was prohibitive. You can see the angular vein. There's substantial tortuosity as the superior ophthalmic vein exits and drains into the angular and then into the facial vein. The course of the facial vein is very amenable to catheterization and traversing. However, inferiorly, you can see that the external jugular vein joins the superior vena cava here inferiorly and through a tortuous communication. So this prevented us from addressing this lesion through the external jugular circulation. We opted to do a direct puncture. This is our depiction of the standard technique where we're working at the medial aspect, the superior medial aspect of the orbit. We puncture into the orbit by deflecting the eye inferiorly with our hands manually. That generally gives us enough room to sneak our needle through and abut the top portion of the orbit, hitting the superior ophthalmic vein, as you can see here, in a relatively anterior position, allowing us then to enter the safe, so to speak, to enter the cavernous sinus in a retrograde fashion. So there you can see a typical example of the puncture site, the medial superior aspect of the orbit, where you deflect the eyeball inferiorly as we're advancing our needle. This is our direct puncture in this case. Here's our catheter now in the cavernous sinus, in kind of the middle posterior third of the cavernous sinus. This is our location here, obviously the superior ophthalmic vein. Here's our catheter entering the orbit percutaneously. After coil occlusion, obviously I was disappointed. We had thought we had gotten a decent coil pack, as you can see here, all the way back into the superior ophthalmic vein, though there is persistence of this drainage posteriorly from the posterior aspect of the cavernous sinus in a retrograde fashion. You can see a pacification of the cerebellar cortical venous system. We had planned to bring her back at 48 hours. On postoperative day number 1 at 24 hours, she had developed a severe headache and had this small amount of subarachnoid hemorrhage in the posterior fossa. You can't leave this alone. This is a high-risk feature. So we brought her back emergently that next day for treatment. I was a little concerned. I didn't think we had a very good route to the cavernous sinus now that we had blocked the ipsilateral superior ophthalmic vein and ipsilateral inferior petrosal sinus. So in this case, we opted to take an indirect approach where we traversed the basilar plexus and entered the cavernous sinus from the contralateral side. Here's a depiction of the anatomy. This is what I'm talking about. This is the basilar plexus, as you can see here, often honeycombed, often many trabeculations from side to side. We opted in this case, as you can see, again, a posterior view here of the clivus and the basilar plexus. We went up from the right inferior petrosal sinus and crossed across the basilar plexus to the left side. This is a venogram from the right jugular vein from a guide catheter, nicely illustrating the basilar plexus. As you can see, this isn't honeycomb, but there are many different communications existing from side to side. This is the ipsilateral inferior petrosal sinus. The cavernous sinus on the ipsilateral side would be located here, but that's not our target. We're targeting the posterior aspect of the contralateral cavernous sinus. So we need to get to this position. That's our target. And this proved to be a very good route to get there. So we went from the contralateral inferior petrosal sinus across the basilar plexus and into the posterior aspect of the fistula. So this is our microcatheter here in the ipsilateral cavernous sinus. We pulled back and then traversed across. This is our microcatheter then inching our way across the midline, and then our microcatheter position here superiorly behind the coil mass. This is our venogram demonstrating, again, the posterior aspect of the sinus draining posteriorly into the cerebellar veins. This was treated in a straightforward fashion through coiling from this pouch and then onyx embolization, really to seal the interstices of the coil mass. This is left internal and vertebral artery angiography demonstrating occlusion of this lesion. There are multiple potential complications from the direct orbital punctures, potential complications, I should say, including hematomas, injury to not only the globe, but the optic nerve and potentially the carotid artery. So certainly something not to be entertained casually. There's a lot of high-end real estate along the route to getting into the vein, but certainly in these cases in which there is a dilated orbital vein, whether it be superior or inferiorly, that does present a very good target for endovascular treatment. So this is a 60-year-old woman with an indirect carotid cavernous fistula. We do see a single branch of the internal carotid artery of the cavernous carotid that goes into the superior ophthalmic vein and cavernous sinus. This is the superior ophthalmic vein here. We tried to simply just get into that superior ophthalmic vein through the internal carotid artery, through that small branch. But we had to do a number of maneuvers to try to do that. Every time we tried to catheterize this 90-degree turn, the microcatheter just herniated superiorly into the internal carotid artery. So we bumped off a balloon that we inflated just distal to the ostium of that vessel. That enabled me to get the wire into the superior ophthalmic vein, though we could never pass that stenotic lesion. So we reverted to a direct puncture. Here's our wire. Again, I was able to hit the superior ophthalmic vein with the needle and pass the wire, but because we had hit the superior ophthalmic vein so posteriorly, as you can see here, I was unable to get enough wire purchase to bring our sheath into the superior ophthalmic vein, so that trajectory as well failed. Looking more closely at her late venous drainage, what we saw was a potential route. So this is the superior ophthalmic vein. These are progressively later venous phases. And what you see is a potential route through the external jugular system. So this is the external jugular rising here superiorly, becoming the superficial temporal vein, becoming the superior orbital vein, and then anastomosing with the superior ophthalmic vein. And as I mentioned here, so what I've done in this AP projection is paste together various late phase venograms to show this route. So now we're looking directly at the face towards the orbit. Let me point out the anatomy here. This is the superior ophthalmic vein, which you can see here. This is where it comes above the orbit. The cavernous sinus would be more posteriorly. The supraorbital vein that anastomoses with the superior orbital vein courses laterally, and then anastomoses with the superficial temporal vein, which courses inferiorly to the external jugular vein, lying lateral to the internal jugular vein. So we were able to do that, traverse this through a transvenous route through the external jugular. Our catheter position is here. We could not advance inferiorly. So in order to prevent what I thought was a real risk of reflux of the onyx into the internal carotid artery, we inflated a balloon across that ostium and simply embolized onyx through this transvenous route. Here's her lateral angiogram demonstrating cure, and this is what we love to see. A week later, I see her in clinic and her eye symptoms have nearly completely resolved. So this was a patient, multiple failed endovascular procedures, but with persistence and analysis of the venous drainage system, you can often find a different route into the vault. There are a number of different trans-IPS routes that can be taken. Certainly the direct route through the ipsilateral IPS to the cavernous sinus is one that we would prefer, tried and true, easily navigable. This is the inferior petrosal sinus here. This is the region of the cavernous sinus, superior ophthalmic vein, which you can faintly see here. But the high-risk features here are twofold. One, not only the drainage into the superior ophthalmic vein, which I think is always a high-risk feature in terms of potential visual loss. But what we see here is the middle cerebral venous drainage, again, coming from the anterolateral aspect of the anterior aspect of the cavernous sinus, and certainly a high-risk feature in this particular case. This is another view of it posteriorly. Again, looking at this region here, the anterolateral inferior aspect of the cavernous sinus. And we're able to go up the IPS in a very straightforward fashion. I like to work from forward backwards. So we get into the superior ophthalmic vein, coil posteriorly. We repeated our venogram from this position, and you can still see that we are not done. We may have blocked the superior ophthalmic vein, which is great, but we still see the drainage into the middle cerebral artery. So you need to continue to pack this, fill the interstices of the coil mass. If you can't fill the interstices with coils, then often you have to use a liquid embolic agent to kind of seal off all of the different interstices. But again, multiple serial angiograms while you're performing this procedure are key to identifying the residual routes out of the cavernous sinus. This is our right common carotid artery post. Again, this is a workhorse route to the cavernous sinus. This is a 64-year-old with chemosis and proptosis. 6-vessel angiography demonstrates bilateral carotid cavernous fistulas. These are indirect lesions. You can see venous drainage not only anteriorly, but posteriorly into the inferior petrosal sinus. We decided to tackle this in a staged fashion, addressing one fistula side at a time. We went up the left IPS here, again, into a distal position in the superior ophthalmic vein. This is super selective venography, again, demonstrating beautiful venous anatomy, the angular vein then coursing inferiorly to the facial vein. This potentially could have been a route for us to get to this fistula. Again, more complicated, more distal catheterization across the face is required. And certainly going through the IPS is a more straightforward trajectory. We were able to accomplish coil embolization of the left cavernous sinus and superior ophthalmic vein. And this is our result. We brought her back the next day to address the right side. And we addressed this indirectly via getting to the contralateral cavernous sinus via the circular sinus. You'll remember now when we blocked the left cavernous sinus, blocking the left IPS. So now we need to get back to that left-sided region towards the midline and work our way back towards the right side. And the easiest route for us to do this is to come from the contralateral side across the circular sinus to our coil mass on the contralateral side and work backwards, again, coiling and repositioning our catheter to try to get to those areas where we know the middle cerebral artery is draining, where it's draining posteriorly. This is our route here, again, coming from the contralateral side superiorly to the ipsilateral sinus and across the midline. As you can see here, there's our catheter position, working our way back, progressively enlarging coil mass. And that went uneventfully. We brought her back a month later, and lo and behold, she still has filling, this time of the inferior aspect of the right carotid cavernous fistula, draining to the ipsilateral inferior petrosal sinus, which you see here. So we went back up, this time again, through the ipsilateral inferior petrosal sinus. And in this case, I wasn't content with my coil mass. There was still some filling of the inferior petrosal sinus. Again, in this case, we used a liquid embolic agent to seal off those interstices and to cure the lesion. 8 months later, she remains cured. And finally, as I mentioned before, the transinternal carotid artery to the cavernous sinus, I think, is a very straightforward way of treating direct carotid cavernous fistulas. If the rent in the internal carotid artery is not huge, it doesn't blow apart the whole vessel, then I think you can reconstruct that with the use of a flow diverter. And this is how we do it. We first navigate a microcatheter through the rent. The rent is up here in the posterior aspect of the cavernous sinus. We navigate our microcatheter all the way to the superior ophthalmic vein. Here it is. With that catheter jailed, we go transarterially again through the internal carotid artery and lay our flow diverter across that rent. And unlike other stents that Elad mentioned earlier, the flow diverters have a high mesh tine percentage and really are the optimal substrate for stent-supported coil embolization. Really nothing will get through the interstices here of this pipeline device, and we can go on to occlude it, preserve flow through the internal carotid artery. Stenting scaffolds are now being used for a number of different types of fistulas. Houdart and his group in France recently published this in the JNIS, I think a brilliant technique in which he partially deploys a stent, doesn't fully deploy it, and then transarterially embolizes with onyx. There's a bit of the onyx that goes into the stent. The stent at the conclusion is recaptured along with the onyx and pulled out of the cranium. So again, I think these flow diverters and stents are different weapons in our armamentarium, and certainly weapons that we use in the treatment of fistulas of all sorts. So to conclude, I've spent a lot of time in the cavernous sinus. These aren't short, quick cases. These are cases that you can spend hours of the day working to reach a conclusion. So there are multiple routes into the safe, but you must close all the doors behind you, particularly those with retrograde cortical drainage. So I thank you for your attention. As I mentioned, I don't think that these techniques will be going away. And just as a quick aside, I remember when I was doing the intraoperative angiography, Greg mentioned our study, and it brings back nightmares to me because of those 200 intraoperative angios. I think I probably did about 180 of those, and those were incredibly disruptive to the day, but important for that study. So thank you again, everyone, for your attention, and I'm pleased to answer any questions.
Thanks, Rick.
Thanks, Felipe, very much. Elad wanted to show a quick 2-minute case that ties up with while he's setting this up to continue. Did I hear you correctly, Felipe? You said you'd like to deposit the coils from anterior to posterior when you go in the SOV? Or
yes. Well, it depends on which way you're going into the SOV. If you're coming from behind from the IPS, right, and you want to go into the SOV, coil occlude it, and work your way back.
Right.
If you're going through the SOV, then you're working from the back of the cavernous sinus anteriorly.
But to summarize, you always, of course, go to the furthest point and then come to the.
Yes.
That's what you mean. Yeah.
Yeah.
Perfect. Okay, Elad, go ahead.
Thank you, Jacques. And Pablo, I won't parasitize your time. Philippe, excellent talk. I actually learned some approaches via the external jug. So this is when we used to do percutaneous, you talked about, can you see this screen?
Yeah.
This is sort of when we used to do percutaneous and we had trouble with hemostasis. Occasionally I had to do awake lateral canthotomies, and this is what our patient looked like after awake lateral canthotomy. He would scream, then we would scream. It was never a good day. But I want to show a quick video of an approach we recently did to complement your fantastic talk. So unlike, I think, Miami and the Barrow, where you have an excellent department and you have other excellent departments, I could not find somebody to help me access the superior ophthalmic vein, which was the only drainage to the CCF. So as a department, so we did this ourselves, this cut down, and I think neurosurgeons, Jacques and everybody else, should become very comfortable and familiar with this technique. And this is, I'll show this. This is only 90 seconds. So basically, it's a small incision between the eyelashes and the eyebrow on the lid. You find that fat, that periorbital fat. Here is, you can see the hypertrophied superior ophthalmic vein. So now we have control. So you're scarred by your own complications. And I didn't want to, when we lost control that other time on the percutaneous, and Philippe, you mentioned that can happen. So here we did a cut down. Here you can see the eyelashes, the eyebrow. And then we basically brought him to the angiogram suite once we had the loops around the SOV. Here you can see a transradial approach. I know Bobby's on the phone, or on Bobby Stark is here, so he'll be happy we went transradial. And then we basically do the angiogram, and you can see the fistula, hypertrophied SOV. It's kinking here. And then just in the angio suite, under kind of controlled conditions, we place a cannula. And exactly what you and Jacques were talking about. Here's our catheter in the cavernous sinus, coiling distal or deep cavernous sinus to proximal. We don't use liquid embolic because you sort of get one shot. And then there's the final. Sorry, there's the final there. It's cured. And then we bring him back to surgery, where we take the cannula, we ligate the SOV, stitch the vessel closed, standard, and then 6-O-proline. And then here she is. And then acutely 1 day post-op, that's her. And then 3 weeks later, she looks a lot better. I appreciate you giving me 90 seconds, Jacques, to sort of complement Philippe's excellent talk with another sort of cut-down approach.
Yes, thanks, Elad. I actually published, before you guys became so good at percutaneous SOV, that's how I used to do them. I think I had like 20 cases doing this open cut down. The first author on that publication is Stacy Quintero, and she was my resident with she did some nice job looking at the series. Absolutely. Yeah, but thank you for reminding us. You're right. Sometimes the percutaneous technique may not work, and that could be the last resort to access the SOVs surgically if all your other wonderful tricks that Felipe talks about. You're right, and you're absolutely right. The oculoplastic surgeons do not know this abnormal anatomy of the arterialized SOV, and really only a cerebrovascular neurosurgeon will understand how to do this. Very nice video, Elad. Thank you. I don't want to take more time from Pablo's talk, so we'll keep overall questions till the end. Pablo, go ahead, share your screen and tell us why Elad is so wrong that surgery is dead for aneurysms.
No, I should I respect Elad?
By the way, Elad, in 1994, I was a resident doing the course that Chris Ogilvie did at Mass General, and Jacques Moret was a visitor, or was an honored guest. And in 1994, he said, neurosurgeons, aneurysm clipping today in 1994 is dead. Now, of course, he was not correct, but there is of course, no arguing the fact that endovascular has gradually taken over the treatment of aneurysm, but I would not assume it's completely dead yet. But anyway, just a fact. Pablo, go ahead.
I don't agree. I think it's alive and it has a very good health. Okay, thank you, Jacques, for the invitation to talk. It was a pleasure to be among this great surgeon. My talk is the essential need of microsurgery in the treatment of brain aneurysm. We know that, at least for me, according to many studies, the great majority of the brain aneurysm are possible to be or to receive both treatment modality. I think the goal of this treatment is a permanent and total occlusion. We have two, classic papers supporting both technique, the ISAT and then the BRAD study. And in both cases, you can they can support endovascular or microsurgery. Something of what is real according to the current tendencies. we can observe some more inclination to the endovascular arm. So we can consider that we are in the, maybe the endovascular era. But I think that there is some still scenarios where the microsurgery is superior for the treatment of the brain aneurysm. I just summarize some case, some situation, but maybe you can find more than this condition, but at least in all of these cases, I think that the microsurgery is still alive and has a real good and clear indication. Let's see some example. In case, before showing some example, the current therapeutic arsenal from microsurgery is clipping, bypass, proximal ligation, and new technologies, new clips.
Pablo, sorry to interrupt you. We don't see the title because there is a white box blocking. Do you see?
Oh, yes.
Do you see the title of your slides?
Yes. I thought that just in my case. Let me put maybe
There's
now.
like a white box with a menu bar at the top of the screen.
Now, can you see now?
No, it's still there. I think that's like can you close it and open it up again? I think there's a tool.
Okay.
It's the tool, you know, what do you call it? The toolbox thing. It's at the top.
Yes. Okay. Let me. You mean I should close the presentation?
Yeah. Ignacio, what do you recommend?
Put play again. Play. Go and play to the right. Oh.
It doesn't disappear.
On the left, it says view. Click on view. On the top left. No, he can't see it. He can do nothing about it, doctor, because he can't see it. It's something that is in the computer.
See.
It's a tool.
Yeah. It's okay. I mean, we can see but just remember, we cannot see like the top space in your slides.
Okay.
It's okay. Go ahead.
Okay, I'm sorry. Let me. Now, can you see this is the current therapeutic arsenal?
Just mention the title of each slide because we cannot read the title of the slides. We can see everything else.
Here, the current therapeutic arsenal from microsurgery, and then from the endovascular arms. So you have many different techniques, but anyway, the first indication, I think this is better for microsurgery and very clear, is when you have a intracerebral hematoma and at the same time you have a Mca aneurysm. Not only Mca, it could be another location, but this is a very common situation. Even you can see in the American Association guidelines, if you have a patient with the intracerebral hematoma, quite big, large, you should do the surgery at least in 3 hours. So you can find some paper that compare with coil and then surgical evacuation and clipping and surgical evacuation. They have a very similar result, but I don't think it's logical that you should carry the patient to the endovascular operating room and then move to the OR. So I think that you can go with the patient directly to the OR and you can resolve the two pathologies in one stage, and the result must be better in case of this kind of patient. You can also see in the European guidelines the same concept. So this is a clear indication for microsurgery in case you have a brain aneurysm. Okay. Here, let me share with you a very short video of an example. This is a patient with a high-grade hand Hess and with this SIH from a middle cerebral aneurysm. You can see this is quite difficult for coil, and the patient also have a paraclinal aneurysm. So you can see the brain is that we call angry brain. So in this case, we just go in the subfrontal approach. We can identify the N1 segment, the aneurysm. We can complete the partial removal of the hematoma. And then you have a more relaxed brain. you can identify the Mca aneurysm. After removal part of the hematoma, the brain becomes more easy to work. You can identify the N1 segment with the temporary clip, and then you just can with the pilot clip or maybe a definitive clip, remove the temporary clip, and then you can complete the removal of the hematoma. And finally, you can clip this aneurysm, as you can see now. And then even you can go to the paracranial aneurysm. You can make a partial cranioidectomy. So all in one stage, less than 2 hours of from the skin incision to the clipping and removal of the hematoma. So this patient with a very bad or quite bad initial condition can be resolved with surgery. I think that there is no room here for endovascular. So this is a clear indication. This is the patient 1 week later. You can see no more hematoma. The patient did very well. So this is a clear indication for microsurgery. Then we can have another situation, SIH, which high grade Fisher scale. So you can see many papers. I just selected 3 papers from the Tanikawa groups. They show that after clipping, you can clean with the nicardipine, and you can clean the basal cister, and they have a less incidence of symptomatic cerebral vasospasms. We have another paper from Mura group from Chile with the similar findings. And on the other hand, you can also find many papers regarding the opening of the Lillywitz membrane and lamina terminalis. The shunt dependence is much lower in this patient in the future. So when you have a patient with the SIH with high Fisher grade, you can do both treatment in one stage. For one, this is an easy Icg aneurysm in a patient with a very unfriendly brain. So just by opening the lamina terminalis, we have more room. We can release CSF, and the brain become much easier to treat. Then you can identify and clip the Icg aneurysm very simply with a straight clip. And after clipping, you can remove part of the clot, and then you can go, I will go fast forward for the time, but you can go remove part of the hematoma, and then you can go with the catheter, just put in the basal cister, in the prepontine cister, and leading with membrane, and you can clean all the cister with papaverine. In this case, we have much better result, less incident of the shunt, and less incident of the cerebral vasospasm. This is the post-op, no blood, no hydrocephalus. Then we have another condition, which is, in this case, more controversial, which is aneurysm with mass effect. In this case, we can consider two groups. I mean, a giant aneurysm and ruptured aneurysm with distortion of cranial nerve. So giant aneurysm is one indication, and the other is the typical example is the Pecan aneurysm that has some compromise and produce oculomotor palsy. So in these 2 cases, we can use both systems. Maybe with the flow diverter is more now, is much better in some cases, but as you can see, flow diverter in this study from China, they have 22 patients and only 54 patients had some improvement, and the rest of the patients remain at the same situation, and even 20% of the patients have a worsened evolution, and 1 patient died. So what I mean that flow diverter is a wonderful tool, but it's not as safe as some people want to say. Okay, and here you can see some meta-analysis. You can see that the occlusion rate is 77.9. You can see that the morbidity and mortality is near 14% of the case. And this morbidity and mortality is higher in giant aneurysm and in posterior circulation. Then you have another paper that you can compare the occlusion rate between bypass and Freud Diverter. As you can see that at 12 months, the occlusion rate is 65% in the Freud Diversion group against near 100 in the surgical group. Finally, here we have a paper from the Canada group. This paper, they say, okay, that the Freud Diverter is not as safe and not as good as everybody knows. So just I want to say, be careful with these new techniques. Here's another paper that you can find that they have some problem. For instance, the delayed rupture after Freud Diversion. In some cases, you have an occlusion and you need to do a rescue bypass, as you can see, as a treatment of this case. And here another paper, this is from your group and Michael Lawton. When you have to deal with the aneurysm previously treated by endovascular with Freud Diverter, you have some problem. For instance, the timing before 3 months increase the thrombosis effect. The temporary clipping is more difficult in these cases. You can have an incomplete occlusion, or after put the clip, a temporary clip, you can have we're going to see a stenotic deformity, especially with the pipeline. And finally, some problems appears when we have to treat this kind of aneurysm with mobilization of the parent artery and visualization of perforating. So we need some new technique to check, like endoscopic or Icg or something like that. Okay. Regarding mass effect, you can see this is a paper a little bit old, but you can see that from years ago, very good surgeon has 100% occlusion and more than 80% of very good result with the acceptable morbidity and mortality rate. And all of these guys, they don't have no retreatment, no rebleeding. So this is another point in favor of microsurgery in this case. This is an important meta-analysis from 39 papers, and they compare clipping, coil, and Freud Diverter in visual field in paraclinal aneurysm. And you can see that the clipping group is better than the coil group, but it's not, but maybe the Freud Diverter group is a little bit better. But in the same paper, if you check, they include the microsurgical series from the 80s. And we can surely say that the technique currently is much safer and better than 30, 40 years ago. So you're not going to compare a technique from 40 years ago. Anyway, if you see the result in this paper, when you compare microsurgical arm in referral center, the results are much better than the normal group. Finally, in the same paper, they found that the decompression is stronger and earlier in the microsurgical side. Here is typical example. This patient came to our hospital with almost left eye blind. We did the MRI. You can see the giant and partially thrombosed aneurysm. We did the Tellurium Approach. I will fast forward part of the video just to show you this is the Tellurium Approach. We did the opening the cerebral fissure as usual. I will skip because of the time, but then we can complete the clinoidectomy in one piece. So we can have a proximal control, we can mobilize the optic nerve, and then we just can put a clip in the neck, then we can open and remove the thrombus and decompress the optic nerve. So this is at the end of the surgery. You can see the optic nerve now is totally released from the aneurysm. And the patient has a very good evolution. You can see the post-op control, and this is the pre-op and post-op visual field. You can see the patient has some improvement. On the other hand, you have, it is very common, everybody knows that oculomotor nerve and Pecan aneurysm, you can choose both treatment, but the recovery in the microsurgical group in many papers is faster and stronger in the microsurgical group. So this is another situation where we can still use microsurgery as a first option in this kind of aneurysm. Here, one more example. I just, similar to the previous case, this is a Pecan aneurysm. The patient has a oculomotor palsy. Maybe you can use some endovascular device, but just identify the aneurysm, the Pecan, the neck, just put the clip, then you can puncture the aneurysm sac. Then you can coagulate and cut the sac without touching the oculomotor nerve. This was a 30-minute intradural surgery. Okay, and after clipping, I just put a second clip, and I'm sure that I preserved the Pecan. I didn't touch the oculomotor nerve, and this is the final view. And here the patient just 1 month later with a total recovery of the oculomotor palsy. Then we can have endovascular failure in case of recurrent aneurysm after initial endovascular coil embolization. We have many papers from different groups. Even our group published years ago our series together with Dr. Mura from Chile. We have many cases. In this case, we choose as definitive treatment the microsurgery. This is one case I'd like to share with you. In this case, the endovascular asked me to treat the Mca aneurysm, and I asked him, what about the ACON? He said, ACON is perfect. Okay, don't worry. So I just did the microsurgical Tellurium approach, opening the cerebral fissure, but I just want to check the ACON aneurysm. When I just put the Doppler. Okay. You can see I put the Doppler in the coiled aneurysm, so there is flow inside the sac. So I just dissect the neck and put a clip. A1 now in the ACON. So the patient is cured now. Then I move to the Mca, just put 2 clips and resolve this case easily. So this is another indication. I will skip this case. It's just the patient, in this case, the endovascular tried twice to put the for the Diverter, they couldn't. So we practice bypass as the typical techniques. And just to show the control, we just clip the aneurysm and did the high flow bypass. In this case, because they couldn't, because I think this is, for me, maybe high flow bypass is decreasing the indication because of the flow diversion. And finally, we have the Mca aneurysm. You have the guidelines from American Association. They suggest Mca aneurysm. Then you have a new device like the web, but as you can see, the occlusion rate is 80% in some cases, but it's not so. It's far from 100 that you can reach with the clip. One more example, just to show you. Very simple mini-Tellurium approach. Just opening the cilium fissure, and in less than 30 minutes only, you can clear this aneurysm easily, and the patient with a very good recovery. Finally, I have some questions, personal bias. Why don't we tailor the indication according to our institutional result or individual result? On the other hand, you can see the PubMed publication the last 10 years. The endovascular group has at least twice publication against microsurgery. Why? Maybe because paper accept something which is new, and the clip microsurgery is something that is already is an accepted fact, that is something that works very well for microsurgery. So as a conclusion, I would like to say that although we probably are in the endovascular era, the paradigm of brain aneurysm treatment in terms of 100% occlusion rate and long-lasting durability is still below to microsurgery. Please do not confuse. Classic is not obsolete. Classic is the highest point of excellence in some art of science. Okay. Thank you.
Thank you, Pablo. Thank you very much. Again, I'm going to save the discussion for after my fellow and resident show you their cases. David, are you on? Why don't you share your case with the panelists and see what they would do about that case?
Sure, let me share my screen now.
Oh boy, you sound so sonorous. Are you in an echo chamber?
No, let me see if the microphone is a little better there.
Okay. These were really fantastic talks, all the panelists, of course, as expected. Yeah, David, whenever you want.
Well, it's an honor to be able to present for you tonight, and thank you to all the fantastic panelists and talks that we've had so far. Thank you to Dr. Morcos for this case here. This is a patient that we saw a couple of weeks ago in clinic, a 63-year-old woman with rapidly declining left-sided vision. She had a left APD and complete visual field loss on that side. Her extraocular muscles were intact. Imaging showed a large left supraclinoid aneurysm, as well as a smaller 4mm ICA terminus aneurysm. This is when she was first evaluated for her vision loss. The head CT that showed a large calcified aneurysm off of the left internal carotid artery, and subsequent angiogram to find that aneurysm a little bit better. AP projection and then the lateral projection. And the question for the panelists will be what sort of treatment recommendation options are available to this patient at the time.
Actually, can I invite my wonderful partner, Bobby Stark, to maybe comment? Bobby, why don't you tell us what you would do?
Yeah, sure. I didn't exactly see where the neck is, other than we saw the ophthalmic, so it looked just distal to the ophthalmic, and I'm guessing, you know, it's before, maybe before Pecan. It's a little hard to tell without a good, you know,
Yeah,
3D.
these are, as you can tell, these are outside angios, and there were no good 3D. That's what we could get hold of. But
Yeah,
tell us your thinking in general. What do you look at and for?
Yeah, I think, you know, these are tough cases and great talks by, you know, both sides of the panelists. You know, I think, you know, that I sort of believe that there's a great role for microsurgery for some of these cases and a great role for endovascular treatment for some of these cases. And a lot of times it comes down to, patient and disease characteristics. Someone who's really elderly and has a lot of medical comorbidities, I would certainly treat this endovascularly, probably with loose coiling and a flow diverting stent. Someone who's really young, I might consider open surgery. And, I'd have to look more closely at the neck to see, is this something that could be treated with simple clipping, or is it going to need a bypass? As the complexity of the open surgery goes up, I'm more likely to favor endovascular as well. This case could probably be done in about 30 to 45 minutes endovascularly. And then the last thing is, how many other aneurysms she has. It sounds like she has another small aneurysm. So certainly with microsurgical clipping, we had a case recently where we treated 6 aneurysms with clipping all at the same time. But then we had another case with 5 aneurysms all along a dysmorphic carotid with a 2 centimeter ICA aneurysm. And we treated all those with loose coiling and 1 flow diverting stent.
So Bobby, then, but Elad is telling you you're wasting your time in your early years going to the operating room. Why are you even applying any skill to this? It's worthless. It's a dead end.
I mean, I think
Jacques, you're intimidating him. He knows every day, 365. This is a flow diverter case. This is a giant ophthalmic with calcium on the CT. You have to expose the neck, get proximal control. This is a bear of surgery. The optic nerve is going to be draped over this. This is an all day, every day. I don't care if you're 25 or 85. Flow diverter case, done awake in 20 minutes. In less time that it took Pablo to give his talk, we'd have this thing treated.
Felipe, yes, agree. Flow diverter, yes. Coils, no coils with it. What are your thoughts?
Yeah, I think, well, we don't really see the neck of the aneurysm very well. That really is that's really the crux of the issue. If you can see it well, then you have a better chance of getting out of the aneurysm. I would hesitate to say that this would take 30 minutes. It would take 30 minutes if you're able to canalize the parent artery, but often what we see in these cases is that it's challenging to catheterize the parent artery, and you often have to use different techniques. So what could take 30 minutes can take 2 hours also, and that could require navigating your catheter over the dome of the aneurysm, trying to get out of the aneurysm and into the parent artery. Really depends on what that neck looks like. But yeah, I would treat this with flow diversion 10 times out of 10. I'd like to see that ICA terminus aneurysm as well. From these pictures, it doesn't look like she's filling her A1 on that side. So she likely would tolerate that A1 gradually occluding. So if that ICA terminus aneurysm was irregular, I would think about extending the construct of the stents into the M1 and across that terminus aneurysm as well, and potentially building a construct down across that large ophthalmic segment aneurysm. I would use coils. I'd put a coil or 2 large coils into the aneurysm, kind of as a wick to get the thrombosis started. I would not densely pack this aneurysm. I think you run into a lot of difficulty and potential challenges with thrombosis of the carotid if you have a compressive coil mass.
Felipe or Elad or anybody, would the rapidity of visual decline affect your treatment or no? I mean, you know what I'm driving at.
That's why I would not put coils in, and this is the art, and it's not wrong to put coils in, but I'd want the aneurysm to involute. And just by putting without creating a coil mass, we have found and have published, and other centers have published, that just taking the pulsatility out of this with a flow diverter, we see many of these patients improve. It would be disingenuous to say all of them, some don't. But just like surgery, just manipulation of the optic nerve and decompression, not all the patients get better with surgery. But to your point, Jacques, when there's visual deficit, I'm very reticent to put coils because I want the whole mass to involute and shrink once we put the flow diverter across.
Felipe, you share that idea, that thought?
Yeah, I mean, I think that's reasonable. That's what I was trying to get to before. And I think in terms of densely packing, then you really do run a risk, I think, of potentially infarcting the optic nerve. But more importantly, in this situation, you run the risk of compressing the carotid artery and occluding the carotid artery. So yeah, I would put a coil or two, again, very loosely packed. I like to use the large penumbra coils kind of to frame it, and one or two coils generally is all I would do. Certainly not a more compressive match. But you know, I have disagreed with a lot over the use of local anesthesia for these cases or sedation for decades, and I won't beat that drum here, but there's absolutely no way I would do this patient awake. I would do this patient asleep, get the best pictures you can of the neck with three-dimensional angiography, patient's not moving, and certainly if you rupture the aneurysm, which hurts, the patient is going to be moving around too much either. So
I will push back, and I love Philippe and have tremendous respect for my friend and my colleague, but this is awake every day, all day. We've published on the safety of doing these awake over the complications in the literature. So again, it depends on your comfort level. I don't like general anesthesia because of spikes and blood pressure, and you lose. As surgeons, we're clinicians. I want to talk to the patient. How are you doing, Mrs. Smith? And if she's telling me she's uncomfortable, I'm probably doing something wrong. So definitely two schools of thought, and no criticism doing this asleep. But just we're sort of a local and awake shop, and that's how we're used to doing them.
I have an idea for another talk for another time. Awake versus asleep. That's terrific debate. We'll build something around it. But Pablo, can I tell you, certainly some of the beautiful post-stenting angiograms that you see after these giants are really stunning. What is your take on this case?
For me, maybe both treatment could be placed here, but I think that the rapid evolution of the visual field deficit let me choose clipping as a first option. Maybe I can do some maneuver at the level of the neck, like a suction, retrograde suction, and then try to reconstrict the artery. And you will have a earlier and stronger decompression of the optic nerve, and maybe the patient can recover his visual field deficit faster.
Okay, David, go ahead and continue the story.
All right, so the patient opted for endovascular intervention, and she had a stent placed from the proximal ICA to the aneurysm across to the M1 segment, so covering both aneurysms. And we have the post-stent placement, immediate post-stent placement angiograms here, AP and lateral.
David, are you guys hearing David?
I think he froze.
Sounds like he froze, or
David, I think we lost you.
Can you hear me now?
Yeah, now I can, yes.
Okay, so I was just saying that the patient had a stent placed that covered both aneurysms, the ophthalmic artery aneurysm and the ICA terminus. And here is the immediate post-stent placement angiogram.
Is this, Felipe, is this looking good at the moment? Is this going to be a good outcome? What do you look for in an immediate post-stenting angiogram for success?
Well, I would say, Jacques, what concerns me is the extent of stasis. So you have to be careful with these patients. The ones that develop stasis immediately are ones that we've seen in the past that can go on to rupture or can go on to thrombose their carotid. So I don't think you're out of the woods yet in terms of this, what looks like an excellent endovascular outcome, at least the treatment phase. But the proof would be in the pudding at 48 hours afterwards, whether or not this aneurysm has remained stable.
Okay, David, continue then.
Okay, so the patient's visual fields improved by 1 month post-op, but by 4 months post-op, left-sided visual complaints worsened, and now with new right-sided vision decline. So this is the MRI at the time, and then another angiogram shows recurrence of the aneurysm with an endoleak around the stent itself.
Yeah, it would be nice to see what the original native views look like, to see whether or not there's true apposition along the carotid wall. I mean, that really is something that we try very hard now to achieve, is apposition along the vessel wall. And that basically is to prevent what David said, which is an endoluminal leak around the stent construct, which can cause thrombosis and stenosis of the vessel.
Yeah, Philippe, I agree with you. Typically, we'd like to push or punch the front part of the stent and really sort of stack it up against a vessel wall to prevent endo leak. And at this point, if at this point, you may just want to stop the dual antiplatelet and keep them on aspirin, and that may lead to thrombosis of whatever the recurrence you have. You're 4 months out. I don't know what your regimen is. Typically, we go 6, but if you're seeing this again, you may want to just stop the Plavix at this point and monitor.
So you think there is still a chance this will thrombose completely?
Yeah, because now the patient's on dual antiplatelets. By removing one of the antiplatelets, you can lead to, over time, you can get more thrombosis in the sac, more rapid thrombosis in the sac, and lead to complete obliteration.
But I mean, she's worsening her vision now, the other side as well. What do you do with that? And also that picture on the left, does it not show that the wall is not well opposed? Replay, David, the left side window.
As you replay, Philippe's point is the perfect point. Wall opposition is key, and you're 4 months out. It may be hard to get the wall opposition at this time. So if you want to try to nurse this medically for a week, you can stop one of the antiplatelets, stop the Plavix, put her on some steroids. And sometimes that you can bridge them through before you take them to surgery and try something surgical.
I mean, I agree with Philippe, and this is why I also like to put, 1 or 2 loose coils in. And, if their vision is really getting significantly worse over a short period, I agree, you could wait a week. But if there isn't, necessarily complete opposition, you could also go in and put another flow diverting stent to make sure that you're getting stasis there. On the original run, it looked like the fellow double injected. So it's hard to assess what the stasis was there because you're already seeing the negative contrast sitting in there, but the stent needs to be well opposed along the whole length. And if it's not, and you haven't put 1 or 2 coils in, then I think you need a second stent or, maybe even a third stent.
Okay. Well, this was done in another state, so that's why we don't have all the lovely pictures we'd love to get. Okay. Well, I haven't done anything with this case yet. I just saw her. Thinking about what our options are, but this is good to hear the discussion. David, that's it, correct, from your case?
Yes, sir. Thank you, Dr. Morcos.
Okay, let me invite our resident, Eva Wu, who wants to show you quickly a case and I thank her for...
Jack.
Oh, Pablo, sorry, go ahead, Pablo. I didn't ask you.
No, I have... somebody say 20 minutes of treatment, but it has passed 4 months. Okay.
Understood.
Okay.
Understood.
Yeah,
Yes.
the assumption was that it was treated appropriately the first time.
I don't know. I'm not sure.
Welcome, Eva, to the symposium that you listen to every month. I know you love those symposiums, so now you're on one of them. How about that?
Thank you. Thank you, Dr. Morcos, for giving me the opportunity to talk today. And thank you for the panelists as well for giving me excellent talks. So I just wanted to present this case today because we have a wide breadth of knowledge from our panelists today. And so to start, this is our case. It's a 71-year-old female who had initially chronic headaches, and she had worsening frequency of headaches. And so she went to her primary care physician, who ordered an MRI brain, which showed an aneurysm. And so then she was referred to us. She has no other focal neurological deficits, no relevant past medical history. We did an angiogram. This is a lateral left ICA injection. You see this ophthalmic aneurysm here. This is an oblique left ICA injection. And so this here is a 3D rotational angiogram, and the aneurysm measures approximately 13 millimeters. And so I just wanted to stop here and turn it over to our panel of experts to see what they would think. And so just in summary, this is a 71-year-old female with worsening headaches and a left ophthalmic artery aneurysm that measures about 13 millimeters. And so what we wanted to ask the panelists what they would do to manage this patient.
So I'm gonna help shorten the discussion. Elad, can I ask you to summarize? All ophthalmic aneurysms are treated. None of them should be treated with surgery, or I guess, is that your position in general?
In general, yes, none of them should be treated with surgery because, and this is 71 years old. That's another reason not to treat with surgery. And again, this is a very straightforward flow diverting case. So I won't waste the panel's time.
Right.
You summed it up very well.
No, that's okay. What I don't think Eva showed here is the cervical ICA is tortuous. Does that ever play into your decision-making regarding access?
It definitely changes the technologies that we use for access. So tortuous anatomy means building a different access route, but it wouldn't change it wouldn't still change how I treat the aneurysm, but I would use different tools to create stability of access depending on tortuosity.
Okay. Felipe, flow diverter as well. She's 71 and
yeah. Without question, I would put a flow diverter. I probably wouldn't coil this aneurysm. I would just flow divert alone.
Okay. Pablo, you want to clip this?
Yes, sure. I think I can clip.
I know you can, but okay. Go ahead. Sorry.
I think that if the patient is 71 years old, but is in very good clinical condition, I think that she can tolerate very well a safe surgery.
Okay.
Jacques, what would you do, Jacques, if this is your 71-year-old mother? What would you recommend?
Well, we're going to show you what I did. This one I did already. So, listen, I love the flow diverter results on proximal carotid aneurysms in general. I just saw that the picture is not there. The cervical ICA is a bit loopy, and I've certainly seen some problems with access when they are like this. And then the vision, I hear you, cutting away the pulsatility may help, but I've also, as you've seen in that other case, it can go the other way. So I decided to operate on this patient. She's really a very good 71-year-old. And the reason we're showing this case, again, to show that sometimes the classic things really do work, and particularly for our young audience to kind of celebrate what I think is a wonderful technique. I know you're going to think of it as obsolete, but it is classic, and that's a Dallas maneuver of suction decompression. So Eva did some nice slides. She's going to show us the case. Eva, go ahead.
Both said that we did the Dallas technique, and so here, this is operative video. We are dissecting the ipsilateral optic nerve here and the contralateral optic nerve here, and I'll just fast forward a little bit. And so here we're doing the clinoidectomy, taking off the last bit of the clinoid here, opening the optic nerve sheath. And then here we're dissecting the aneurysm. This is the ICA.
And oh, by the way, for the young audience, look at the mark on the optic nerve. Look at that strangulation of the optic nerve with that line, that purple line where the distal dural ring was. It's remarkable how, yeah, I mean, no wonder they get worse. And of course, surgery, I mean, surgical results can be very bad on the vision. And the Dallas technique really allows the minimal manipulation of the optic nerve. Go ahead, Eva.
And so here, the ICA again. And so now we shift our focus to the carotid exposure, and so we're dissecting out the carotid. And so here, I just wanted to pause here for a few seconds and just turn our attention to this animation here to the left. And so as we play the video, the next steps will be depicted on the animation as well as the video. And so here, this yellow arrow shows the normal blood flow going through the carotid. And so going back to the video, here we put a vessel loop on the common and the external carotid, and we're cannulating the common carotid with an 18-gauge angiocath, and then we connect that to this arterial line tubing, and then that's connected to a 3-way stopcock, and then we connect 2 60cc syringes, so one's filled with heparinized saline, the other one's empty to allow us to aspirate from the carotid. And so, sorry, one second. And so here, you can see that we placed the 2 bulldog clamps. Sorry about that, technical issues. We placed 2 bulldog clamps, one on the common and one on the external carotid. And then this, we placed a temporary clip on the distal ICA, so distal to the aneurysm and proximal to Pecan. And so after we obtain proximal and distal control, you can see that the blood flow changes. And so now there's retrograde blood flow from the ophthalmic and the 3 cavernous branches into the aneurysm and causing the aneurysm to remain persistently filled. And so as you see that once we do suctioning from the syringe, the aneurysm deflates, and then allowing us to further dissect the dome of the aneurysm and for clip reconstruction.
Yeah, Eva, thank you for, I know you spent quite a bit of time with the beautiful illustration, and thank you so much. Yeah, we can go to the end and really
So here we just close it with the purse string. So this is the CTA. It shows that the aneurysm was clipped and the patient did very well post-operatively.
So, you know, just the classic things still work, no disagreement, and that it, let's stop sharing. So I open up to questions for, thank you, Eva, for putting the case together. Let me see what there are questions from the audience. I know Felipe may have to leave in a few minutes. We just have a few questions. We don't have Greg to ask him. Okay, we'll skip that. Felipe, does the choice of embolization agent make any difference during the embolization for CCF?
Sure. Yeah, I tend not to use liquid embolic agents as a primary embolisate in the cavernous sinus. If I had to choose one liquid over the other, I would use Onyx. Glue, as Elad mentioned, you have one shot and a bit less control in terms of where the glue is going, so I'd be hesitant to use it. I rarely use Onyx primarily as a means of occluding fistulas, but I think it's an excellent way of, as I mentioned before, filling the interstices around the coil mass. But you have to be careful about retrograde flow into the internal carotid artery. So in some of those cases, I do inflate a balloon in the internal carotid artery. There's debates as well about Onyx toxicity, case reports of cranial neuropathies afterwards. I'm not sure whether or not it's the toxicity of the DMSO that causes that, or whether it's actually occlusion of cavernous branches to the ophthalmic nerves or to the cranial nerves that causes that issue. But those have been reported, so it's not my primary means of treating them, but it's certainly a very good means of finishing them off.
Visich Srinivasan, who thanks you, always come to the Symposium, it's good to have you, has a question. To what extent could the French technique of retrievable stents be used in the ICA as well for CCF? Yeah,
I'm looking at Visich on my other screen because he's our fellow upstairs getting started on a basilar aneurysm. Yeah, so
well, next time teach him properly so he doesn't have to ask questions. He should know that.
I will. I'm going to go up there and reprimand him. That's a very good question. I would not use this technique intra-arterially. So Hudart used that in the sinus itself, and he used that to capture the onyx. But as you can imagine, when you're capturing that stent, you're advancing a catheter back over it or you're pulling it. And regardless, it constrains the stent and can cheese grate the onyx, which is not a big deal on the venous side. You're rarely going to have a large enough onyx cast where you're going to create a significant pulmonary embolus. We're talking about maybe 1 or 2 cc's at most of onyx within the venous system that if it does break off from the stent will go inferiorly. And I don't think that would be problematic, but I would not like to see that on the arterial side where you cheese grate the onyx while pulling the stent back and it can go north. So I'd be hesitant to use that technique arterially.
Okay, Felipe, I'm going to keep asking you because I know you may have to leave. Daniel Encarnacion is asking question about, do you monitor ocular flow after use of microcatheter through the ICA and you embolize superior ophthalmic vein? How do you monitor ocular flow in case of complication of the brain stem like edema? How do you manage? I don't know if you get the gist of his question.
Yeah, I do. I have never seen a problem from that in particular. I've not seen ischemia to the optic nerve or acute visual loss as a complication of occluding the cavernous sinus. So I don't routinely assess flow dynamics in treatment of carotid cavernous fistulas. Maybe Elad or Bobby could speak to other points there, but I don't think it's an issue.
I mean, I think we look for the choroidal blush, and then if you're worried about any issues, the ophthalmologist can dilate, look for an APD. They can do OCT to look at the nerve. They can do fluorescein angiogram to look at the microstructure of the vessels, but usually that's preserved.
Okay. Pablo, Dr. Felipe, good. You have to go. Good.
Good to see you, my friend. Thanks to all my friends on the panel. It was great being part of this.
Good luck in the clipping of the basilar aneurysm that you're doing right now.
I'm just thinking about how I'm going to harvest that occipital to get the SDA.
Do you drive to work on a horse and buggy, or do you actually have a vehicle?
I'm riding
going to coil this basilar.
I've got
I assume you actually have a car.
I've got my own donkey, Elad, that I'm going to be riding upstairs. Okay.
Well, I'm sure if you're driving a donkey to work, I'm sure he's got a cart of clips in the back for your basilar.
Take care, guys. Good to see you.
Thank you, Philippe. Pablo, Dr. Gupta Uday would like to tell you that there are also studies, and he's right, that show that clot removal and irrigation have no effect on vasospasm, and it's controversial. What are your views?
I think that, yes, there is controversial point, but you have the paper from the Mura group, maybe 10 years ago, and later a new paper from Tanikawa group, and they show that the incidence of delayed vasospasm is lower after a controlled cleaning of the basal cistern.
Let me ask Bobby. Bobby knows the literature inside out. He's been part of it. Bobby, what is the state of knowledge on, washing out subarachnoid blood and vasospasm? What's your take on it?
So we have one of the true experts at University of Miami. Unfortunately, he wasn't able to join, Ricardo Comatar, who, when he was at Hopkins, wrote up an article on the Hopkins group, which I think showed that fenestration of the lamina terminalis led to less hydrocephalus. Then he went to Columbia, summarized their group, which showed that in a separate publication, showed that fenestration of the lamina terminalis didn't affect vasospasm and hydrocephalus. And then he wrote a third paper, a meta-analysis and review of the literature, and summarized over a couple thousand cases. At least in the meta-analysis and the review of the literature, I don't think that showed a benefit on hydrocephalus or vasospasm in terms of fenestration of lamina terminalis and washing out clot. But I think it also depends on how you manage the EVD. Some places leave the EVD in longer and some places do more frequent lumbar punctures. And those places probably seem to have less shunts and maybe even less vasospasm as well. So my general feeling is I usually, if I'm there, I do it. And I think it probably does have a beneficial effect, but I don't know that that's clearly shown in the literature.
Okay. Dr. Natal, it's good to have you with us. Edgar Natal from Mexico, spectacular cerebrovascular microsurgeon. He was commenting that the case that David showed is a ventral paraclinoid. Yes, you're right, it was ventral, and it can be reconstructed by open surgery. Well, you heard them, Edgar. They would. Well, I guess you wrote the question before you saw the rest of the case. Thank you for commenting. Jorge Mura is very upset that we talk about surgery, like it's something very invasive, and we've had him on the panel before. Good to see you, Jorge. We've beaten that discussion over, so we're going to skip on your lovely question for now. Okay, Dr. Montero, regarding complex aneurysms treated endovascularly, can you comment on the risk that a residual filling stable for a long time would pose versus the risk of it being treated with open surgery initially? Elad, I guess, why don't you take that?
Yeah, that's a great question. Whoever asked that, I'm going to share this screen. So we wrote a paper called Neck Remnants and the Risk of Aneurysm Rupture After Endovascular Treatment with Coiling. And I believe there were close to 1,000 or 10, I forget how many, let's scroll down, but it was multi-center, and the rupture was zero. So the title is Much Ado About Nothing, and I was forced to put that title because I wanted something more aggressive, like who cares, but or something even more aggressive. But this is an important paper that our center, as well as several other centers, wrote in 2019. So that's a great question. It was 1,300 aneurysms. Dr. Capuzzo, my future partner and fellow, just told me 1,300 aneurysms with residual necks, unruptured, zero rupture risk. So that's a great question, and it's something we need to talk about more. It's okay to have a little residual neck, and we have residual necks in surgery. We have dog ears. Spetzler talks about it. I know my colleague and friend Jacques talks about dog ears. It's not a ruptured aneurysm. In an unruptured aneurysm, a residual neck is okay. We follow it, and it's had zero risk of rupture. But great question.
Yeah, but obviously, naturally, if they stay stable, I agree with you. The problem is the ones that then become like a wounded animal that, like the case we've shown before. Yeah. They grow, and then you end up with something a lot more complicated. Anyway, I don't want to drag this too long. Anybody has any comments to anybody else? Pablo, Bobby, Elad? No, we're good. I think we covered all the questions from the audience. As expected, fantastic panel. I always enjoy. Oh, Greg, you're back. You probably missed everything. Any comments? You just, okay.
Just want to say thank you again, and sorry I missed a lot of the discussion. I apologize.
Was it a recurrent hematoma from a post-op clip, Greg? Is that why you went back?
Acoustic neuroma. Jacques didn't teach me well enough how to get them done fast.
Oh my goodness. I've finished mine at 2 o'clock. What the heck are you doing? Okay. Okay. Guys, thank you. Wonderful to see you all. Thanks very much. Elad, Pablo.
Thank
Bye,
you.
guys.
Bye.
Thank you, Jacques. Thank you, gentlemen.